fast, so we'll... Welcome to the afternoon plenary, everybody. A couple of announcements. Firstly, please note that Mrs. Susanna Jakob is not able to attend the conference due to emergency meetings, so won't be able to give the plenary later this afternoon, but we're very fortunate in that she will be replaced by Dr. Elke Jakubowski. I've been asked to remind you, please, to hand in completed quiz forms to the University of Glasgow desk by 11 o'clock tomorrow morning. That's in the exhibition centre. There may be the occasional tweet going out with answers to quiz questions, so if you're struggling, have a look. Also, please complete voting forms for the best posters at the conference and hand completed forms in to the registration desk by lunchtime tomorrow. So, on to this afternoon's plenary. I'm very pleased to introduce the moderator, Jose Martin Moreno, who's Professor of Preventive Medicine and Public Health at the University of Valencia and advisor to the WHO Regional Office for Europe. Thank you.
Thank you to Alistair, our excellent chair of this wonderful European Public Health Conference. I'm delighted. It's a privilege to be here with all of you, even though I cannot hide that my mind is also with a person very close to my heart who had a bicycle accident on Tuesday. And that's demonstrating in practical terms that healthy lifestyles and healthy behaviors need to have a supportive and healthy environment to be effective. It's not enough to be willing to do the right things, it's also to do the things right? And, well, let me try to pull myself together, and I am just going to enjoy this exciting plenary session with wonderful colleagues, and to set the scene and to see what the rationale of these communicable and non-communicable diseases all challenges novel solutions. Because the idea is that even in UFA, we have a section on chronic diseases and a section on infectious diseases control. And there's a false paradigm surrounding the idea that they were silos. And we know that some communicable diseases are chronic, HIV/AIDS, tuberculosis, and meaning that their control is very similar to the one on non-communicable diseases. And at the same time, non-communicable diseases can actually be communicated. There are infectious agents causing certain cancers, for example, but at the same time, there are social norms and constructs which spread unhealthy behavior, like smoking, drinking, and bad diet. Marketing is contagious. So from that perspective, many people also are suffering from more than one condition at once, the so-called communicable and non-communicable diseases. So in a nutshell, we need to move on from treating diseases to citizen empowerment and caring about people. So the modern approach, at least in theory, would be go from silos to systems, breaking down barrier after barrier, separating different functions, disciplines, fields, and sectors. That was the rationale of putting together this very important session. So the conceptual links between different areas are more fluid, but on practical level, barriers may still remain. So public health approaches and primary health care as the person-based anchor should be the solution, we believe. So our aim is to forge a convergent approach from an integrated public health perspective. That would be, in a nutshell, the challenge of this. How to improve the efficacy of a system approach to public health so that all actors are working together. And in order to do that, I have the privilege to introduce 4 wonderful colleagues, and all of you here in the room who are already converted, so we are speaking to the believers, but we need to actually be persuasive and politically proactive. Here we have Dr. Marc Springer, the Director of the European Centre for Disease Prevention and Control in Stockholm, and Dr. Simon Cagewell from the UK, Professor of Clinical Epidemiology at the University of Liverpool. Both of them will have 15 minutes for their presentations. And the idea is to have them a panel discussion with Ora Timmen, who is the president of the UFA section on infectious diseases control from the National Institute of Public Health in the Netherlands, and also Iveta Nagyová from Slovakia, is the president of UFA section on chronic diseases, also at Safarik University in Slovakia. you know, the ground rules of the idea is to have an open discussion at the end of the presentation and right after the thoughts arising from the panel discussion. That would be our dream if we have time, and then we don't talk a very long time. And remember that we have the possibility of sending questions to the speakers using this Twitter wall with the hashtag EPH Glasgow, with the kind of things of how to better integrate communicable diseases prevention into primary care, or prevention, how to do these global emergency issues and pathways, both for communicable diseases and non-communicable diseases, including education, promotion, empowerment, restructuring of health services, primary care, health in all policy. And finally, one question that I'm going to pass to my colleagues immediately. Silence, just researching and publishing in a humble way, or advocacy, or we need to be activists? Which option is the right one? So with this in mind, let's enjoy the presentation and discussion. Thank you so much. Dr. Marc Springer will start with a vision on communicable diseases from this integrated approach. Marc.
Good afternoon. It's a great pleasure to be here in Scotland. Last time I was here, I went to gardens, beautiful gardens. I bought a lot of seed, hoping to create a beautiful garden at home in Holland, but it didn't work out that way, unfortunately. I would like to tell you something about infectious diseases. And if you would ask me, what are the major threats, I would answer that it's AMR, antimicrobial resistance, the vector-borne infections. Actually, when I wrote this, I didn't know about the current Ebola outbreak. STD, pandemic influenza. Nowadays, we have the new avian flu, as you know. Foodborne disease outbreaks, vaccination fatigue. The movement of people and migrant health, and I'm very glad that you are paying a lot of attention to this theme, and the multi-drug and extensively drug-resistant TB. Now, I would like to give you a bit more information on AMR, on vector-borne infections, and on TB. And in fact, all challenges require new solutions. Now, if we go back 10 years ago, maybe you recognize this picture. This is Hong Kong. And that was the doctor there in the suit, who was a doctor who had treated a patient in mainland China and who became ill overnight. And as you know, this was the start of SARS. Now, amazing, the same night, or the morning after, 4 people were infected. And they went back to their home countries, but 4 different continents. Now, I'm still impressed that the world was able to control this outbreak. And I was wondering, how did it come? And I think it was because there were strong healthcare systems in place, Canada, Hong Kong, and so on. There was a very coordinated international response, and there was an intersectoral approach. And I think that was the way to control, to stop this outbreak. In fact, it was also a little bit push for ECDC to create a European CDC. Nowadays, we have an ECDC. The mission is to assess risk assessment. It's important to mention to you that we are not in charge of taking measures. That's up to the member states and to the EU. And our tasks are to gather information, to do intelligence, to produce a rapid risk assessment, scientific advice, support preparedness of the member states, and last but not least, EPH and UFAM training, very important training programs. This is a very important picture. I believe that public health is like a clockwork. And like we are sitting here, we are all parts of this clockwork. No one is the boss. And it can only work if we work together. Then we are able to have good health systems. Now, you know these pictures. It is from West Africa. It's about Ebola. And some people are asking me, journalists, media, so what is the figure of today? that's important to know, but do we know the actual situation? I'm afraid that we don't know, because as we are sitting here, I think we are trained in setting up surveillance systems. And we have all systems in place, we have computers and so on. And we know actually the situation of diseases. But is that the case in West Africa? I'm afraid not. A lot of people are dying on the street. They are not able to enter any center. No epidemiologist is able to reach them, and they will never ever enter any register. So it's good to know that we only know a tip of the iceberg of what is happening there, unfortunately. And you know these pictures. It's really touching. People are just laying on the street. They try to get a place in the treatment center. But, you know, they can only get a bed if someone else will die. And important to realize that there's also civil unrest. And I don't know whether you have seen an article in the New York Times of yesterday about Liberia, that there are huge conflicts between several stakeholders, and that, you know, there is lack of elements in the whole chain of control. So what are the key actions to stop the outbreak, the SARS? And let's look in this case here. There is no health system in place. There is no healthcare system. Is there an international coordinated response? Yes, of course, but wasn't that a little bit late? And is there really a holistic approach? I'm not so sure. I think it's a fragmented approach. But in Europe, we are doing much better. This is a picture of Germany, Frankfurt, an exercise. We have, you know, this fantastic personal equipment, protective equipment, and in Europe, we know how to treat patients. One patient, 30 medical staff. We use 25 protective gears a day, 24 hours. That's how we do that. But this is the way to control in Europe a potential outbreak. I'm not afraid that we will get an outbreak in Europe. It's because we have a very good health system in place in general in Europe. We are very well prepared. We have a health security committee that's on the umbrella, that's part of the EU legislation, and I'm sure that there is a holistic approach. That's how we deal in Europe. But mind the gap. I was really impressed by the title of this conference, Mind the Gap. You see the difference between Africa and how we are treating this. I would like to show you this picture here. I think everyone is familiar with this. It's, you know, the success of public health, partly, but the development of penicillins was, of course, antibiotics was very important. And thanks to the new wonder drug, antibiotics, it was able to see a further decrease of mortality. But unfortunately, it doesn't work always. And if we don't have effective antibiotics, we are not able to do a hip or knee replacement. We have problems with organ transplants, with cancer therapy, with intensive care, and so on. And the question is, what are the facts regarding antimicrobial resistance? And it's striking to see the difference between North and South. One can wonder, how is this possible? And this is a picture of the MRSA, the hospital bug. And it's not only bad news, because it is possible to change the tide and to see a decrease in some countries. And that's a very important message for politicians, to know that you can change this. This is, unfortunately, not a good picture. This is about Klebsiella pneumoniae, and we see really dramatic increase of AMR. And you can see in Italy, in Bulgaria, Hungary, and in Greece, it is a very bad situation. Recently, data were published about Italy. It's the resistance against colostine. That's the very last antimicrobial we have for Klebsiella pneumoniae, and in some parts we see a resistance of more than 40%. That means that we don't have anything to treat patients. So, you know, patients will die because of pneumonia. And this has to do with the relation between the use of antibiotics and the emergence of resistance. Now, this is another interesting picture. You can see that there are some countries in the top. It's the Netherlands, it's Estonia, it's Sweden, and on the bottom you see Romania, France, Greece, threefold higher consumption of antibiotics. A very important question is, how is this possible? Are people more sick in these areas? Maybe it has to do with behavior or psychology. I would like to know that from my colleagues in the panel here. What can we do about AMR? First of all, we need to develop new antibiotics. It's not that easy. Infection prevention and control is important. Very simple, wash your hands and so on. And a prudent use of antimicrobial agents, of antibiotics. Hand washing is key. But it has to do with behavior, with discipline. It's not that easy. And I think it's important to get you support how we can change behavior. It's the same with self-medication. In some countries, you can go to the corner of the street, to the pharmacist, and tell them, you know, I don't feel well, or my child is sick. Can I have antibiotics? I know you for 20 years. Yes, you will get it. That's happening in some countries. So what is key to stop AMR is to have a good healthcare system in place, but also pay attention to cultural aspects, to communication, to, in fact, educate citizens, patients, that they don't need antibiotics. And also same for doctors, and to have a holistic approach with also the veterinarian sector. Let's go to TB. It's another interesting story. But it's also a bit a sad story, because it has to do with social inequalities. And here you see a child. We know that there is a strong decrease of TB in general in Europe, and that's of course good news. Here you see another graph about decline, but we also know that there are about 5 member states with well-known high burden of TB. You see some Baltic states, Romania, Bulgaria, and Portugal. And we need to pay attention to this. But on the other side, we know that there's also urban TB. So we know there are some very vulnerable groups in our society that do get TB. And you know these beautiful pictures of a city like Stockholm, but in each of these cities, there are some groups who are not that privileged. Here you see a picture of Bucharest and a picture of Paris. And that's in every big city. But it's important to know that we need to pay attention to TB control in these big cities. And it's also mentioned in the reports about health inequalities. And nowadays, we know that in some big cities, the incidence of TB is higher than in other countries where we are always paying attention to. It has to do again with healthcare system capacity. And that's why I was very pleased to have a joint mission to Romania. Romania is the country with the highest burden of TB. And together with WHO Europe, this is Hans Kluge, I had discussions with people of the ministry. This is the Minister of Health, and actually I left Romania much more optimistic, because I think they are committed to improve the healthcare system and also to improve the control of TB. And wouldn't it be a dream that we get all children free of TB in Europe? Unfortunately, that is not the case nowadays. There are children who don't get the right treatment. That's why I would like to show a very brief 2-minute video clip. Can you start the clip?
The elimination of tuberculosis in the EU will not be achievable until we have the first generation of children free from tuberculosis in the EU. Tuberculosis, TB, among children has not disappeared from Europe, even though we may think the disease is no longer a problem. In fact, the incidence of childhood TB is on the increase in many parts of the EU. In the last 10 years, 40,000 children in the EU got sick with TB. The vast majority of these caught the infection from an adult in an EU country. To break this chain of transmission from adult to children, early identification and prompt treatment of adult cases is fundamental. This would help to prevent the outbreaks of TB in households and schools that are a common source of infection for children. Proper contact tracing of adult cases can reduce the emergence of TB in children. Early identification, proper treatment, and contact tracing of adult cases are the key elements in achieving the first generation of children free from TB in the EU. Only then will we have the opportunity to eliminate tuberculosis from the EU.
Can you go back to the slides, please? Yes? So the pictures were real, no fake pictures. So the take-home message is political will and investments in health systems are so important. Strong health system in place is vital. Coordinated international response, intersectoral approach, and pay attention to, I call it, holistic communication, health education. And I'm still impressed by the title of this conference, Please Mind the Gap. The gap is huge in Europe. Thank you.
Thank you so much, Marc. And now, immediately, I'm going to invite Professor Simon Cakewell. Do we need pills or we need policies? Because it's not about only, obviously, we need to beat TB, but we need to beat all the so-called non-communicable diseases. Do you have the solution, Simon? I know that you could speak for hours because you're a wonderful expert, and you warned me that I should call you when you 5 minutes, okay? Thank you. So 15 minutes for him, but he could speak for hours on this, I know. Thank you.
Jose, ladies and gentlemen, thank you very much. I'm going to echo Marc's messages. In particular, we are public health professionals here. We stand on the shoulders of giants. We learn from science and we apply these lessons to the future successfully. So, optimal NCD prevention strategies, pills or policies. Thanks to many people for inviting me, Martin McKee, Martin O'Flaherty, who did the work, and many others. I take funding from scientific agencies. I do not take money from the food or tobacco industries. I'm going to touch briefly on the burden of non-communicable diseases, the fact that there are only 4 major risk factors, the fact that population-wide policies, prevention policies are very powerful, pills are not. I'm going to talk about the obstructions from vested interests and how we can learn from past successes. In terms of non-communicable diseases, they account for 2/3 of all deaths in the world. Cardiovascular disease alone, 17 million, going up to 22 million very soon. 4 major risk factors. The first hint from a PLOS study from Harvard, suggesting that diet was much more important than smoking and physical activity. And then in 170 countries, the Global Burden of Disease study, published in The Lancet over a series of months, a major achievement. So mortality burden, disability adjusted life burden along the x-axis there, a bewildering number of contributors. But let's look at these carefully. We've got smoking, we've got alcohol, and we've got physical activity. Pretty much everything else is poor diet. Poor diet accounts for at least 40% of all NCDs, possibly as much as 2/3. So poor diet actually explains more non-communicable disease than tobacco, alcohol, and physical activity put together. This is my first take-home message. How are we going to fix it? We've had falls in death rates from heart disease NCDs in all of the Western countries. We've studied this extensively, and overall, some 2/3 of the fall in death rates can be explained by improvements in population risk factors, just 1/3 from treatments. For the USA, for instance, we have 340,000 fewer deaths in 2000 compared with 1980. Treatments explain 47%, risk factors 61%. It would have been more, but some risk factors got worse. And I think you can guess which ones they were: obesity and diabetes. So these are much more powerful than the treatments. If we look at treatments in this slide, they're the white stippled bars, the risk factor improvements are the black bars, the white are the bit that we can't explain. You'll see that over many countries, risk factor improvements are bigger than treatments. And then when we look at the countries where policies, public health policies, are most advanced, in the Nordic countries, Sweden, Finland, and Iceland, then that accounts for 2/3 or 3/4 of the improvement. Population policies are powerful. Policies are more powerful than pills. If we look in more detail, we'll find that diets explain more of the falls in these death rates than treatments, than prevention treatments. So in the States, for instance, if we think about the reduction from cholesterol, 150,000 fewer deaths in 2000. Most of that was due to secular trends in asymptomatic people, diet in other words. If we look at blood pressure reductions, another 120,000 fewer deaths, mostly asymptomatic people, mostly diet. And tablets, much, much smaller. There are the statins. Since 2000, statins have probably doubled, so we're probably hitting the 40,000. But still, policies in the richest country in the world, policies are still more powerful than tablets. And I could show you similar studies for the UK and elsewhere. We all know about upstream and downstream. Do we pull people out of the stream drowning, or do we go upstream and fix the cause, mend that bridge? There's an effectiveness hierarchy in public health. If we look downstream at the prevention interventions targeting individuals, then we consistently find that they are weak. They achieve a smaller public health impact than the upstream policies like regulation or taxes. I could give you many examples. Jose will only let me give you one. So I'm going to show you a slide where the size of the population health benefit goes on the y-axis, and we got downstream to upstream interventions. I could show you tobacco, alcohol, diet, salt, physical activity, but here's the data. Tobacco, advice to individuals in a few centres, pack health warnings, abolition of marketing, and then tobacco price right at the top. It's a nice effectiveness hierarchy as you go from downstream to upstream. And these things happen very quickly. Martin O'Flaherty and I got this into the Lancet a couple of years ago. Whether we look at diet changes in Poland or Cuba, blood pressure tablet trials, moniker analysis, or the Predimed randomized controlled trial, change the diet, you get reductions in death rates within 2 or 3 months. Very rapid. Here's the Predimed study published in the New England Journal. It compared traditional Mediterranean diet with extra olive oil, 4 tablespoons, or a handful of nuts against control. And this is what we found. Here's the control diet, event rates going up over 5 years, a 30% reduction with a handful of nuts or extra olive oil. That effect is much more powerful than statins in the same population. If only it was that simple. We have significant opposition from vested interests, which is where it gets very political. So increasingly, papers have recognized this in the Lancet, in PLOS, and elsewhere. The reality for food is that 10 corporations control almost everything we buy. Think back to the food you have bought in the last 2 days. I guarantee you will have bought one of these logos, and it's actually controlled by a very small number of companies: PepsiCo, Nestle, Mars, and General Mills, and so on. All of these companies, all of these corporations prioritize profit. They do not give a stuff about public health. The Lancet, a couple of years ago, did a very nice article. Rob Moody was the first author. Fantastic title, Profits and Pandemics, the Prevention of Harmful Effects of Tobacco, Alcohol, and ultra-processed food and drink industries. And the main message is that they all behave the same because they all have one single objective, and that is to maximize profit for their shareholders. They care about their image, they will do public relations work, but if public health is an issue, it always gets suffocated by the profit motive. And of course they use dirty tricks, or as Martin McKee would say, denialism, undermining public health. Tobacco, alcohol, food, sugar industries all use the same dirty tricks. My wife, Anne, and I put this into the BMJ as sleaze tactics, S-L-E-A-Z-E. The industry claims scientific conspiracies. They use logical flaws in their argument. They select evidence to try and contradict us. They demand perfection. They say, is there a randomized controlled trial for sugar? No? Okay, we don't believe you. They use all sorts of zany arguments and distractions, and they buy scientists all the time. They did it with tobacco and with alcohol. Now they're doing it with food and with sugar. If you get a strange report in the literature, just look and see who is funding that scientist. There's often a very dirty explanation. So, what can we do? We can celebrate previous successes. Safe drinking water, slavery abolition, road safety, air pollution, smoke-free legislation. All of these things have been achieved, and the list will continue. There are some very consistent lessons here. I don't have time. Jose will not give me time for slavery, 5 minutes. But I will highlight Richard Smith's article in the BMJ in 2012. He was summarizing a book by Hochschild called Bury the Chains, The British Struggle to End Slavery. The lessons for us today are crystal clear. The abolition movement developed a vision, they developed strategy, and they developed action. And their action was very, very effective. They used performance, props, and stories. They had clear evidence of the injustice, the cruelty, shocking cases that caught attention, powerful first-hand accounts, and iconic pictures. So, Joseph Turner, Mr. Turner, the movie, this is the man. He actually indulged in propaganda. This is the slave ship, slavers throwing overboard the dead and living persons. And just here, we've got a living person with a manacle about to drown. Not bad for Victorian propaganda. So they had vision, they had strategy, they had action. They had good cops and bad cops working within the government, within the system, and bad cops outside throwing rocks, getting attention, raising public awareness. They had visionaries and they had realists. All of them were essential for the total movement. The lessons for you and me, fairly obvious, I think. They can be summarized, whether we're thinking about clean water or slavery or smoke-free, as the support structure. You need scientific understanding. This understanding needs to spread. Professionals need to accept the paradigm. We need to make public and politicians become aware, and then to get on board, become supportive. We can guarantee vested interests will oppose, and this must be overcome. It will not be overcome with voluntary agreements or partnerships. You need regulation and you need taxation. That's what works for tobacco, for alcohol, for sugar. So, I have a couple of conclusion slides. I would suggest that the non-communicable disease burden is immense, but it is eminently preventable. The big risk factor is poor diet. I would suggest that population-wide policies are the most powerful prevention approach. They're rapid, they're equitable, and they save money. There's an effectiveness hierarchy here. Policies are much more powerful than pills, much more powerful than advice to individuals. The politics are inevitable. You either get involved or you watch things fail to happen. Vested interests must be overcome. We know it's going to work because of the previous successes with water, sanitation, and so on. And every time we see this pathway from the initial science through to the effective interventions, regulation, and financial policies. So, like Marc, I think that the current challenges for public health, whether it's infectious disease or non-communicable disease, these are substantial, but they resemble the past. We have triumphed in the past. If we work together, I think we can succeed in the future. Thank you very much.
That's wonderful, Simon. I apologize for the time pressure. Let me disclose that he had 91 slides. And he was able to summarize in such a wonderful way, these 91 slides, and to keep the message, clear. Policies are much stronger than pills. You have convinced us. Also, advocacy and even activism is really necessary for us. So immediately, Ora Timin, who is the president of the UFA section on infectious diseases control, what is your perspective? Because before, Marc was mentioning about Ebola, and actually we know that in West Africa, for example, the population of countries affected by Ebola virus disease are not mainly dying by Ebola virus disease, are dying by many other things, right? Maternal child lack of support, lack of deliveries, diabetes, lack of control, even poor diet. So in some way, what is your vision of this integrated kind of public health approach in order to tackle the problems of human beings, trying to bridge the
I think it's obviously the answer to everything, actually. And what we've seen now with Ebola in those countries is that because of the Ebola outbreak, that the burden of other diseases is increasing, that people are dying, women are dying at childbirth because they are not going to the hospitals to get treatment because they are afraid of Ebola. Children are dying of malaria because they don't get treated. So actually outbreaks of infectious disease only increase the burden of what's already happening there. So actually an infrastructure that tackles both communicable, non-communicable diseases within coherent policies, that's probably the answer. But if you would like from me to hear how to do that, then I'll have to pass the word to somebody else.
Well, obviously, this is the challenge, collective challenge that we have. By the way, you have questions, use the hashtag. But let's try to see if we can allocate a little bit of time, at least, for this exchange. Then, Iveta, what do you see that how would be the link, the lessons learned, and actually the case of tuberculosis that was shown by Marc, the very powerful messages given by Simon on the support acronym? I love that. And actually the nudge concept to make the healthy options the easiest options. How can we actually try to integrate both?
So, good afternoon, ladies and gentlemen. First of all, I would like to express my gratitude to the organizers of this plenary session for choosing such an interesting topic, or an exciting topic that means the interlinks between communicable and non-communicable diseases, or infectious versus chronic diseases. Our section was established in 2006, and the aim of the section is to increase and spread knowledge on chronic disease control and management. And our section tries to identify common approaches to develop the evidence and information base needed to guide policy and identify best practices for combating chronic diseases. And so, since 2006, we have organized over 20 workshops with various organizations and pre-conferences, such as with various partners, such as WHO Europe or European Commission or DG Sanko, and also a number of UFA sections like public health monitoring and reporting, urban health, migrant health. But I have to admit that we have never organized anything together with the section of infectious disease control. And in my opinion, this to a certain extent reflects the situation in the real world. I mean, where communicable and non-communicable diseases or infectious and chronic diseases are considered to be two separate worlds. But as we heard today, obviously they are clearly related, because many chronic diseases have infectious origins, so infectious agents are likely to determine more cancers, immune-mediated syndromes, neurodevelopmental disorders, and other chronic diseases. And examples were mentioned here, like HIV, AIDS, chronic liver disease, Lyme disease, or acute T-cell leukemia, chronic gastritis, chronic ulcer disease, cervical cancer, and so forth. So what I would like to address and stress today, and what was I very pleased to hear, is the usefulness of the concept of integrated models of care, which can work for both infectious and chronic diseases. And even if this model was originally designed to overcome the inefficiencies and fragmentation of current healthcare systems and to meet the complex needs of patients with chronic diseases, I strongly believe that it can work for both groups. And I will come now slowly to answering your question. But first of all, I would like to just continue a little bit that this model is, the basis of this model is population-based or population-wide health promotion and disease prevention, including immunization and vaccination. And already here are very clear interlinks with infectious diseases. And, but another part of the model is promotes patient-centered and lifelong approach, and it stresses patients' responsibility and patients' competencies in care. So what the future healthcare system needs is informed and activated patient, willing to adopt changes in lifestyle and health behavior which are beneficial to health. And here I again come back to the presentation by Marc Springer about health behavior and use of antibiotics. So if we have informed and well-educated patient, it is the patient who can do the right choices in their lives regarding antibiotics or another links with infectious diseases. Many infectious agents are causing chronic inflammation in the body. And being a psychologist, I really strongly believe between links between psychosocial aspects of health. So stress, depression are causing, again, inflammation in the body. And we have results from patients in cancer or HIV that they have more poor health outcomes. So I don't know whether to continue more or to give space to the audience, but also into another part of the chronic care model or integrated care system is information system, which involves data collection and both at population level, where we mentioned that we need harmonization and international coordination of data collection, but also at the individual level, represented, for example, by individual patient records. It would be fantastic if we have this, because having data from various specialists and having access to data can help in earlier detection of certain diseases. So, and then earlier treatment, like Lyme disease, for example. In the beginning, it has very unspecific symptoms, but when we have all the information together, the treatment can start earlier, and we prevent later complications like neuroborreliosis or Lyme arthritis or these kind of diseases. So what the aim is here is to reduce the impact of chronic diseases by interrupting infection, because before it becomes irreversible.
Great,
yeah.
Great. I think you cannot say more in a shorter time. This is the kind of challenge that we have and we face. I would like to open the floor, because this is important participation from the audience, if you wish. If not, let me ask just a question to the panel. Yes, there is one where? I don't see anything. Number one. Yes, please.
I think it seems to me that the two slides of the presentation, which I enjoyed very much both, have slightly different causes. Or to put it another way, my understanding is that a lack of regulation, the profit motive is the big bad evil for public health. It's much easier in many ways to see from Simon's presentation the profit motive in action, making us eat a bad diet. It's less easy to see the profit motive in the perhaps overuse of antibiotics in Southern Europe, or the failure, I suppose, to reduce TB, for example, in children. And I wonder what the panel thought of that.
Great. You want to start?
Yes, it's interesting that if you look at the use of antibiotics, there is regulation that in Europe it is not possible, no, it's not allowed to get it over the counter, so without a prescription. Nevertheless, that happens in some European countries. But even with this regulation, let's say the leeway to prescribe antibiotics is a very cultural issue. And we know, I think we all know very well, that if you go to a doctor in France, that you are supposed to get a prescription. And if you look at the figures I showed you, France is a country with one of the highest consumption of antibiotics. And this is not necessary. If you look at hospital infections, again, it is about behavior. So there is really room for improvement. And I think that it has to do with communication. And I really hope that you can support us in how to do that, how to get the message across.
Yes. Very quickly, Ora?
Yeah.
Because there are more questions.
I'll be very quick. Obviously, I don't have to explain to you as an audience that when there is a problem, you have to look into the determinants of that problem. So the Netherlands, with respect to antimicrobial resistances in humans, actually uses the smallest amount of antibiotics in Europe, but it's high. It used to be the highest in veterinary medicine, so in animals. So then when at a certain moment the antimicrobial resistance emerged in livestock in the Netherlands, we got together with the veterinarians and looked into that problem. So how come we use so much while other countries seem to manage with much, much less? So it turns that we had actually veterinarians who owned pharmacies and who had somehow certain reason to prescribe antibiotics to the whole flock of animals whenever one animal got sick, or even preventive. So then there was regulation put in place a few years ago in which the minister said, we want to decrease that with 60% or 70% within 4 to 5 years. And a few years later now, we are at a decrease of about 50%, even more, because that's the way we decided. We don't do that anymore in the Netherlands. There is transparency. They are not allowed to own anymore the pharmacies as veterinarians, and we managed to reduce the consumption in animals. So again, an example of an incentive, commercial incentive that has been reduced by proper, actually, public health partnership with the veterinarians and proper legislation.
Excellent. We have three people in number 3 and number 4. Let's gather the questions and comments, and immediately we will have, okay? Yes, please, there.
Thank you very much for a excellent panel presentation. I was very pleased to finally see public health physicians actually talking about policies. And the first thing I would like to say is one of those policies, informal policies that should happen, is not to blame the victim, not to blame the patient. And I'm afraid that my view is that talk about personal responsibility is blaming the victim. We've got to get away from that and start looking at the environments in which people live, which people have all talked about. And in my jurisdiction, which is Victoria, Australia, we have set up a community-based randomised controlled trial of communities to develop systems of prevention which are policy-based. And if you Google Healthy Victoria together, you'll actually find a lot of the information about it. But let's stop blaming individuals and start empowering individuals.
Thank you so much. In number 4, please.
We have heard from Simon's presentation in particular the impact that driving companies and pursuing profit have. Now, companies are social constructs, and most of our economic developments pursue growth. Looking at the vision that Simon is inviting us to develop, I wonder if the panel members could articulate a vision for our economy and how the world should go, so that we do not have adverse consequences in health that we currently see.
Thank you so much. Finally?
This is really for Simon as well, but the others may have a comment. John Frank from Edinburgh. Simon, as you know, and I know you've struggled with this publicly, to your great credit, the National Institute for Clinical Effectiveness, Health and Effectiveness in July issued guidelines, new guidelines for cholesterol use in the UK, which will almost uniformly put people over 50 on statins for the rest of their life, about which we know absolutely nothing concerning the side effects after, say, a decade. Secondly, the 500 and some page detailed clinical, epidemiological, and economic analysis by NICE, which I read every page of so that I can teach critical appraisal of it, makes no mention of the values that are being promulgated by this extraordinarily unhelpful guideline. There's no broader discussion of what it will mean to have that much of a population on a class of drugs every day for the rest of their lives. What are we to do when science, so-called science-based analyses, produce narrow policies that may do more harm than good?
Well, wonderful questions. So there is an opportunity, Simon, for you first.
Okay, thanks. The short one first. Thanks, John Frank. We have flagged the issue at NICE, and it's not just that there is a rather irresponsible recommendation that everybody over the age of 55 effectively gets statins, but it's the process. And the majority of people on that panel were actually receiving money from drug companies who will benefit from wider use of statins, who will benefit from wider prescription of the second generation lipid-lowering drugs. There is a spectacular conflict of interest which NICE have acknowledged but refused to deal with. So we think there is an underlying issue here. I take your implicit message. It's clearly inappropriate for them not to state values. It's clearly inappropriate for them to jump to a medical solution for what is actually a social challenge. In terms of don't blame the victim, then my comment would be I agree completely. In the UK, we have a difficulty with a very right-wing government, And so there is a very sad alliance between the right-wing ideology, which says it's up to you, which happens to reinforce the donations to the government political parties from big industry, so they maximize profits for their friends in food and tobacco industries while singing the individual libertarian message. The third thing, how do we regulate multinational companies without restricting economic growth? I think it's perfectly possible. We're not suggesting that we strangle Unilever or Pepsi or Coke, but I think it's possible to force them, require them to behave in an ethical fashion and to promote public health rather than to generate disease and death. I think we can transition through regulation and taxation where there is a much more satisfactory solution, a win-win solution.
Wonderful. Yes, Yvette.
I would like to acknowledge also the comment on not blaming the patient, because I think this is really important to stress that we have to make, like was also said, to make the healthy choices to be the easiest choices for the patients. And this morning we had a wonderful workshop together with the WHO Euro Division on Non-Communicable Diseases and a live course, Gordon Galea, where there were presented very clear examples about the policies and taxation on tobacco and food and how it influences health. So we have quite a lot of evidence already from published work by David Stackler, who is the UFA policy lead here, or Martin McKee, just to mention a few important UFA names. And I really think that UFA should work on moving forward this policy and at the European level, and to really make the healthy choices to be the easiest choices for the patients and for people in general.
Yes. Thank you so much. Laura, please. What would be your view of these three?
This plenary meeting was also preceded yesterday by a meeting with the ECDC, a pre-conference on actually lessons learned from non-communicable diseases in health promotion to be applied in communicable diseases and the other way around. And we were talking about the contagiousness of settings. Of course, in infectious disease, one infects the other, but also non-contagious diseases are actually infectious. And that's what we discovered yesterday, that it's the environment, the setting that makes people get fat, get ill. So if you tackle the environment, the setting, then you will have a lot of gain in terms of healthy people and in terms of years gained. So actually that would be, for me, the message also for you, the contagiousness of actually non-contagious diseases through the setting where they take place. So influencing the setting will influence the diseases.
Mark, please.
Yes, the question about the economic model is very interesting. We know for sure that the current economic model that is based on return on investment and maximize the profits will not work for new antibiotics, because if you have new antibiotics, in fact, you should not use it, only when it's really needed. So that's a problem. We also know for sure that it did not work in order to develop an Ebola vaccine, because in fact there was no return on investment. So we need to look for other models in order to get these necessary drugs.
Great. This is a topic which is wonderful. I mean, it would take hours and hours. We are seeing right now some of the questions from the Twitter world, from Alistair, from Martin, from Tavi. I don't know if we will have a confidence interval of 5 more minutes, because they are so important. Martin was saying for health system it's crucial issue simple versus complex, and not so much communicable versus non-communicable diseases. This is important, and I would like to just as a final reflection for the 4 of you, just to grow on this and also on the other points that were in the Twitter. A vision of healthy growth, maybe Happy Planet Index, and genuine progress indicators, nest growth in sustainable well-being. This is a nice suggestion by Tavi Tillman. And Alistair was saying, can TB be eradicated in Europe alone, or do we need to tackle a global view? And the question is, do we need vertical programs sometime? You know, tuberculosis, national plan, HIV/AIDS, national plan. cancer plan, cardiovascular disease plans, and so on and so forth. When people may have, and we know, cancer and at the same time diabetes, how do we tackle this kind of approach in which we center in human beings, trying not to blame the victims, as we said before, try to empower there, and actually many of the topics that have been addressed in this wonderful conference on health literacy, of empowerment, on human-centered and solidarity is actually brought up, and we can stand up and really be an activist for that. Simon.
Thank you, yes. To respond to that and to Martin, then I think in terms of healthcare, we're talking about universal healthcare systems funded by a tax base. There is a massive evidence to show that they are effective, they're equitable, and they are also efficient. All other models are more expensive. It's very sad to be in the UK where we are being forced to privatise our healthcare by right-wing politicians. I think Martin's right about the simple versus complexity. If we have a comprehensive system, if we have a comprehensive arrangement for healthcare, it can deal with system challenges. It's exactly the same for public health. Many of the challenges in public health are wicked problems. Simple solutions attacking one target are simply not going to work. It has to be a comprehensive strategic approach, and that requires national institutes of public health, which are funded by the taxpayer, which are completely free of industrial influence. There are no conflicts of interest at all. All other models look very weak compared with that.
Wonderful. Iveta, please.
Yes, I like very much this comment on simple versus complex systems and communicable and non-communicable diseases. I think already during this plenary it was shown that the vertical model, well, it works in certain cases, but definitely we should promote more the horizontal approach and the integrated care. And I'm really big advocate of that because of multimorbidities, comorbidities. So we really have to take into account more system elements and also intersectorial, multidisciplinary teams and so forth. So,
thank you so much. Ora.
Well, just to repeat a one-liner that everybody knows, we should tear down those walls within public health. So that was probably the most inspiring thing I've seen today here that emerged from this discussion. So yes, if we manage to do so, then we will have simple systems that will work for everybody.
Marc, please.
Yes. Talking about health systems, I would like to keep it simple. I think we all have a responsibility in getting the right information and have a special eye for vulnerable populations. That's one thing. We need to get the evidence across to politicians, and I hope that the politicians are willing to show leadership. Next, commitment, and then start coordinating the fight against NCDs or infectious diseases.
Thank you so much. Actually, this is wonderful. Time is over. I would just echo the comment also by Andrea Labruto. It's true that economic pressure and conflict of interests are jeopardizing population's health. And he's asking a question, should we still stay silent, blind, and polite? I think the answer from the panel has been no. Try to stand up, raise your voice, do your best. Let's do something. Not something has to be done. Let's try to do something in this public health community and mind the gap. Thank you so much.